medications that you can use for this. But in the meantime, what has been the phenomenological meaning of the slowing of the person's behavior and thought, or of the feelings of worthlessness, or of the suicidality, or of the despair? Because there's going to be a meaning. Whatever a person does or shows you is embedded in a whole complex network of history, of experiences, of feelings and images. And phenomenology is not going to worry about classifying, is it this, or is it depression, or is it not depression? It's going to take each individual feature and try to find its unique meaning in the context of this person's world. So, so you're a depressive. And I flash a little bit on an experience my wife had actually years ago. She was depressed and feeling bad and had a number of these symptoms, and she went to a psychiatrist, and he listened to her story, and then having heard about her sleep disturbance and she was feeling bad about a number of different things, he pronounced the diagnosis. You have a dysthymic disorder, my dear, and we're going to put you in treatment for this. This is treatable. There's no reason for you not to avail yourself of the treatment that's available. She was very upset. What she wanted to do was talk about the meaning of her different feelings that she was having. She was looking for a phenomenologist. Instead, she got to a medical person instead. To her credit, she didn't go forward with that therapy, and she went with somebody else who was ready instead to hear the meaning of why she was feeling as she was feeling, which meant a journey into her own history and world and marriage to me, and the whole story of what was involved there. Now let me give you a different example. I had an experience when I was a young postdoc working in a psychiatric hospital that I'm going to tell you about and use to kind of explain a new instance of a diagnostic category and try to show how anti-phenomenological it is. Long story short, when I first went to Kansas City, Missouri, where I had my postdoc for 3 years, back in the early 70s and late 60s, every morning, or actually I was on Monday morning, there would be a team meeting consisting of a psychiatrist, a couple of resident psychiatrists, the chief psychiatrist, me, another psychologist, nurses, a couple of social workers, and so on. And we'd review the patients that had come in over the weekend, look at their charts, hear their stories, and the first task at hand was to give a diagnosis. And so one morning, as I went in there, the first patient to be discussed was described by somebody who had interviewed him earlier in the day, and some history was read a little bit about it, and the question became, is this patient schizophrenic or not? That was almost the first thing you do, not ask what happened uniquely in this life, but is he an example of the mental illness known as schizophrenia? And Dr. Gray Woodman, the chief psychiatrist, decided to put some pressure on me. I was a brand new PhD, brand new clinical psychologist. And he said, in words just almost exactly these, I remember it's a little bit traumatic for me. He said, well, we have the esteemed Dr. Atwood with us today, Dr. Atwood. Maybe you could help us decide whether this patient is schizophrenic or not by reciting for us the 4 A's of schizophrenia. Then we can decide if these A's appear in this case and make a definitive differential diagnosis. So review those for us, Dr. Atwood, please. Well, I never heard of the 4 A's of schizophrenia. I'd heard of schizophrenia. I'd memorized 10,000 textbooks, but none of them had mentioned the 4 A's of schizophrenia. So I had to finally just say, well, I'm sorry, I don't really know the 4 A's. And he said, well, we're very disappointed in you, Dr. Atwood. I suggest you be looking this up. And so I did look it up, and I'm going to tell you what they are. And now you'll know, so when somebody asks you this, you'll be able to recite them. What are they? First, a disturbance of the logical association structure of thought. You can remember it by words that begin with the letter A. Association, associational disturbance. An associational disturbance means that thought does not proceed along linear, logical, Aristotelian pathways, where premises combine to lead to logical conclusions. Instead, thought veers off on all kinds of strange tangents and associations, and conclusions are reached that do not follow from premises. Okay, that's one. That's the associational disturbance. you know, like the Aristotelian logic goes like, all men are mortal, Socrates is a man, therefore Socrates is mortal. But a so-called schizophrenic might say, all men are mortal, Socrates is a man, therefore I had sex with Socrates in a bathtub last night. Okay, just boom. The men on hooks are at work again, guys, because they're floating there over the sea of humanity, and this patient was one of the people in the sea. And they note that he says things like that, and they look up into the Golden Globe, and guess what? Up there, reasoning is perfectly linear, perfectly logical. Conclusions are reached impeccably. It's Aristotelian syllogisms all over the place. Step 1, step 2, step 3, step 4. None of this veering off into weird tangents that don't make any sense at all. So an associational disturbance is one of the symptoms. Maybe he's schizophrenic. What's another one? The A is affect, but the idea is inappropriate affect. The notion being that emotions sometimes split off from thought, and so there's a kind of disconnect between the coordination of cognition and affect. So people have emotions, and they show emotions that are completely, outrageously discrepant from the content of what their thoughts are. I'm trying to think of what an example might be. A woman comes and tells you that her father has just died, and then bursts into gales of laughter. That would be considered inappropriate affect, because the affect that would ordinarily be appropriate for loss would be all the emotions that are connected to grief, sadness, for example. But instead she's in gales of laughter. And the idea is that in a so-called schizophrenic, feeling and thought get disconnected from each other somehow. And having been disjoined, people have all kind of positive affects with thoughts and experiences that are intensely negative, and the opposite could be true as well. You could have very good things happening, and the person is weeping instead. So the idea is the affect doesn't go with the thought. There's been a slippage, a cognitive affective slippage. That's a symptom of schizophrenia. So affect, the third one. This is what I should have said I should have been able to review, and I wasn't able to remember the thing. The third one is autism. The word autism for this is not early infantile autism, like autistic children. This is not that at all. This is autism in the sense of being absorbed in a world of one's own self-imaginings, like in a world split off from ordinary reality, disconnected from the objective external world, consisting of delusions and hallucinations, beliefs that no one else regards as true, and hallucinatory experiences that no one else can verify as happening. Okay? So being lost inside of a world of one's own imagining, that's the autism. And the fourth one is ambivalence. The idea being that the person's emotions are all positive or all negative and nothing in between. That a person's feelings toward other people tend to split between total unambivalent love or total unambivalent hatred. Like the normal man in the globe has mixed feelings about pretty much everything and everyone. But a schizophrenic has all positive or all negative feelings, and never the twain shall meet, is kind of the idea. So that's what you can say are these are the four intercorrelated deviations that are grouped here. Then a word is put upon them, like happened with depression too. That word is schizophrenia. But then the word schizophrenia is reified. It's thought to be an actual mental disease, perhaps a brain disease. Is there actual medical science to support the notion that this is a brain disease? I don't think there is, and I've looked into it quite deeply over many, many decades. The science is just incredibly weak that would be needed to support the claims that are made. But what's really happening here is you've just got four intercorrelated deviations from the norm again. A label's been placed upon them, and then this is theoretically reinterpreted and reified, and we have instead then a person who's got an internal mental illness. And now we're looking at the symptoms that they're showing, okay? So I want you guys to get used to this idea. Like every single diagnostic category is like this. It's a set of intercorrelated deviations from the ideal. The task of diagnosis is figuring out which class you belong in. And what it ends up leading to is an attitude clinically where you're pigeonholed as suffering from this or that mental illness, and that pigeonholing doesn't even touch the phenomenological meaning, and it operates as a barrier where you can't go forward with it. Now, what I'd like to do is go further with my examples and to give further idea of what I'm talking about, but I need to stop right now for today, guys. So go home.